Perfect. Well, good evening to all. Thank you, Kin Awards, for giving us the opportunity to me and my colleagues to present today the rationale of why we chose to do what we do today in implant dentistry. Not to underscore any other given implant supported prosthesis placement in the anterior maxilla, a precise prosthetically guided digital planification, delivery, and manufacture helps us clinicians to successful treatment outcomes amidst an enhanced communication between a teamwork of surgeon, prosthodontist, and lab technician, all full knowledgeable on the biological foundations of wound healing for a careful treatment planning of either extraction or immediate implant placement with temporalization, the latter as the standard of care whenever possible. When planning an implant support in the aesthetic anterior maxilla, we need to acknowledge, first and foremost, that there is a strict relation between the alveolar process and the tooth it supports. Secondly, that the aesthetic outcome of an implant support rests primarily on the influence that the soft tissue volume has over the buccal bone wall and vertical crest bone loss. And thirdly, that a carefully planned automatic extraction, immediate implant installation, hard and or soft tissue graft, and prosthetic temporalization should be the standard of care when facing a condemned tooth, especially in the anterior maxilla, in order to obtain a predictable aesthetic result with a plan that will limit buccal contour changes and enhance changeable thickness of the peri-implant soft tissue, coronal or away from the crest of bone of the implant abutment interface or micrograft. All of this accordingly to the dual zone therapeutic concept. Both tooth loss and implant placement induce inevitable physiological, traumatic, or pathological resorption and bone remodeling of the buccal bone in all directions, thus affecting soft tissue levels and aesthetics. Sorry about the mishap with the slide presentation. In order to avoid it disappearing completely, the buccal bone wall, due to the natural thin buccal bone wall dimensions of the area, and enhance the gingival thickness of the peri-implant soft tissue, we must render a 2 millimeter or more of buccal bone and soft tissue thickness to counterattack the anesthetic effect of bone resorption and gingival recession that follows to accommodate an appropriate biological width. Following a full medical, clinical, and 3D digitalized prosthetic-driven analysis of the residual bone and soft tissue housing site to be implanted, diagnosed as a grade 3 class 4 defect, we proceed to perform a surgical rigid fixated horizontal and block xenograft with particulate allograft filled bone regeneration and an upper labial frenectomy. It is of the utmost importance for an uneventful hard and soft tissue wound healing to occur to surgically obtain primary closure of the grafted area by means of a specialized curvilinear flap design that limits scar formation and subperiosteal dissection, aided all by a wound dressing. Surgical antibiotic prophylaxis is mandatory for an uncontaminated head and neck surgery when a prosthetic device is to be implanted against the installation of resistant bacterial biofilm. This, co-ed with a topical prescription of a combination of toothpaste, mouthwash, and gel with bactericidal, virucidal, anti-inflammatory, and moisturizing effect, favors an environment for angiogenesis to occur uneventfully that prompts a faster wound healing as seen in a short 2 weeks post-op control here. At 16 weeks post-regenerative surgery, we proceeded to a second patient full 3D digitalization in order to design and install at 18 weeks post-op a prosthetic-driven guided surgery of an implant support. Time at which the xenograft has not only provided the scaffold for osteoconduction to occur by the modification of the bone turnover or remodeling of the vital and non-vital bone interface, preventing further post-surgical traumatic bone loss, but also a lamellar bone compaction that provides a sufficient load-bearing surface appropriate for the installation of an early load implant. It is this possibility, the possibility that renders a 3D prosthetic-driven guided surgery planning those thrills and allow us, before any incision is made, the precision to install and transfer surgically by means of a 3D printed surgical guide all the necessary biomechanical parameters to deliver a successful replacement in the anterior aesthetic zone, conveying all of the following: an early load implant placement in a grade 1 class 1 transformed residual bone and soft tissue housing site that renders us with a 2 millimeter width of buccal bone wall and the need to establish concurrently a connective tissue graft to provide a 2 millimeter width of labral gingival tissue thickness. A subcrestal protocol for an implant installation to 4 millimeters to the adjacent tooth cement enamel junction to allow for the establishment of appropriate biological width of 3. By repositioning the implant abutment interface, or what we know as microgap, at this level with a 3 millimeter height prosthetic abutment will provide us a 1 millimeter of intraclavicular gingival margin positioning of an aesthetic provisional restoration that renders sufficient space to allow for a smooth transition from a round platform to an anatomical cervical tooth shape, influencing positively not only with the formation of the peri-implant soft tissue, but the marginal gingival level, the papilla height, the gingival arch, the labial alveolar profile, and the gingival collar. All of this in accordance with the dual zone therapeutic concept of the critical and subcritical contour of the implant abutment and crown. The choice of an implant anchor that by the design and manufacture is not only inducive for osteoconduction, but minimizes the crestal buccal loss long-term by allowing for platform switching to a smaller diameter abutment than that of the implant, thus shifting the force stress concentration away from the cervical bone implant interface. The choice of a guided osteosensification osteotomy drilling protocol to favor bone compaction in order to achieve the required initial bone-to-implant contact and primary stability for an early load implant in a poor bone density result post-regeneration D3, D4 to a D1, D2. By applying the ACP concept of zirconia adhesion not only to the definitive prosthetic, but to the temporary restoration, we counterattack the detrimental effect that an early disruption on the integrity of an early load implant prosthetic guided osseous integration and soft tissue biomechanical establishment by design will incur, especially if it occurs before the third week of insertion, when the crossover of primary and secondary stability renders a loss of over 50% of the first, time at which the secondary stability process of bone remodeling by turnover of the interface begins to yield lamellar compaction at 8 weeks. The advent and constant development of chairside CAD/CAM materials regards mechanical and chemical stability, biocompatibility, processing, and finishing yield us with all the necessary biomechanical properties that an immediate implant-supported prosthesis demands for successful treatment outcomes. Predictable, successful treatment outcomes like this can only be possible with a common goal-focused professional teamwork, aided by a well-established digital protocol workflow. It is appropriate to conclude with that within the multiplicity of factors to consider in the planning and execution of a dental replacement with an implant-supported prosthesis in the aesthetic anterior maxilla, the most important to consider in summary are the following: a minimally invasive extraction, a correct 3D guided positioning of the implant, a subcrestal implant installation to 0.5 to 1 millimeters, an aesthetic tissue reconstruction of both biomaterial and connective tissue graft, a soft tissue thickness of over 2 millimeters, an ideal contour of the provisional for tissue support, avoid disconnections, the use of ultra-polished zirconium, and a screw restoration for cement control. And that is that. Thank you.
Okay, so José.
Anna, you may want to start.
Buenas
No,
tardes.
you can do it, José. Make yourself comfortable. You're the first.
But
Okay.
not the last.
Delmy, first of all, primero de todo, muchas felicidades por haber sido seleccionada entre los 5 finalistas, los 5 mejores. I shall continue in English, I think. So first of all, my congratulations for sharing the case and for participating and being selected on the top 5. It is very nice to see how digital dentistry is taking part of our clinical cases, and we are using it to ensure the best treatment possible option to or outcome for our patients. So that, I think, it's the it's the best value of the case. Of course, you ensured very well the 3D positioning of the implant, and this is very much related to a proper gingival margin position. So I think that the 3D planning helped you on achieving that. On the other hand, I'd like to ask you, if you had to do the case today, if you had to do the case today again, would you change anything on the performance, on the surgical interventions you have done? Is there anything you would do different?
Anything that I would do different? I hope I don't sound cocky, but I wouldn't change a thing. I mean, I can only resume this case, in 10 minutes. So far, I tried to do it the best that I could in order to get all of the parameters. But we need to establish, and the audience needs to know that this, I don't have a magic wand. This doesn't happen by magic. I mean, in order to see these beautiful results, this conveyed hours, days, and weeks of planning, you know? So really, that is the beauty of 3D, a prosthetic driven digitalized workflow, a well-established digital workflow. The beauty is that we have the opportunity before any incision is made to anticipate and have whatever control we may have in all of the possible outcomes that during the surgical performance we can prevent. So this is one of my star cases because with the planning, the performance, and the results, of course, aided with all of the wonders that Kin products offer for my post-surgical patients, and because the benefits I have seen over the years have been invaluable. I mean, I cannot work without the aid of chlorhexidine, alpantha, hyaluronic acid, and that really accelerates the healing process. But honestly, Jose, I'm sorry to tell you, but I don't think I would do anything differently. I think all the steps were followed very precisely and beautifully done. I mean, you can tell by the results.
Yes, but Delmy, I'm so happy to hear you
I'm
feel so
sorry.
proud of yourself, which is great in life, not only for dentistry, but probably for many other personal and personal things, But I'll give you my little advice if you allow me to.
Of course.
Evidence has related shorter papillas, particularly distal shorter papilla to the implant, every time we raise a flap. I see Olivier going like this. A friend of us by the name of Jan Cosin, who's a fantastic guy, brilliant on anterior implant placement. Not that you're not, because I mean he does basically what you did, being helped by guided surgery. Has published a few papers testing and proving that every time you raise a flap, papillas medial and distal to the implant become shorter, and particularly the distal papilla. So if you critically analyze your case, which looks very nice in regards to the mid-facial position, the papillas, particularly the distal one, is shorter. And I bet, and I know Jan Cosin takes it very seriously, as we all do, and you do, that if you hadn't done the two flaps, your papillas would be longer. So now you got your facial contour, which is great, and you managed it very well. But for the next case, I push you to look at the papillas, the length of the papillas, as the next step. And menos es más. I say it in Spanish. Less is more. Also for implant dentistry, also for the front area. Okay. Tiny flaps. You please take advantage of the guided surgery to do a very tiny incision and undermine the connective tissue. Okay. Use a narrow implant if needed. You will prevent from doing block grafts. Okay. Block grafts have shown the worst aesthetic outcome in the front area. Okay. In a comparative study as well from the group of Ghent. Okay. So, but in any case, this is just an advice. Your case is very beautiful, and I love the passion you put on it. Okay. Así que fantástico. Si estuvieras aquí te daría un abrazo. Básico,
me encantaría,
básico.
José. Me encantaría.
Beso.
Ahora,
Beso.
I would really just like to comment a little bit on that, because I totally agree with you. But the fact is that I don't think it is in the presentation really appreciated, because I know the concept and I have done exhaustive research on the area, but even when I performed the block graph with the curvilinear flap, I don't know if you were able to appreciate that I did a papilla preserving, I raised a papilla preserving supraperiosteal flap with deepitalization of the papilles and overlaid them in order to gain more volume of papillary tissue. And the same principle was used when we re-raised the flap in order to put the implant. Of course, I had to do an extensive subperiosteal flap in order to remove the rigid fixation. But I always rest assured that in both surgeries, I did a papilla preserving, I raised a papilla preserving flap in order to counterattack the shrinkage. So you are completely right.
Thank you, Delmy. Congratulations. Thank you.
Hello, Delmy.
Hola,
Very and very well documented case. I want to ask you something because it's a really young patient. He only had 21 years old.
Yeah.
Am I right? Okay. Was it suggested to the patients to undergo previous orthodontic treatment? Did you?
No. The thing is that this was we received this patient by referral. The history that he just wanted. He suffered a traumatic avulsion with an evolution of approximately 3 years. He never had any treatment done. He didn't even wore a provisional of any sort restoration for those 3 years. And he was referred to us because his consultation question was, listen, what can I do in order to get a frontal tooth again?
Okay.
So, and that was a beauty, because when we performed the reconstructive surgery, we didn't even have to worry about a professional because he was not wearing one for 3 years. And that did wonders for the healing as well. You know, because we counterattack that micro movement, that any removable, even Maryland prosthesis produce a micro movement and pressure that will result in less reconstruction.
So he didn't wear anything.
Anything, because he never wore anything for 3 years.
Okay. Just for curiosity, you used a soft brushing kit.
Yes.
What do you think about it? Just for my clinical curiosity. I want to hear about your expertise of using that.
The soft
brushing kit for processed shock room.
Yes, of course. My experience with that kit.
Yeah.
Okay. I hope nobody here has any commercial things. You know what? For us surgeons, Anna.
Okay.
I am. You know, I mean, I think I use it. I own it. We use it, but it takes longer. Yes. And I don't get whatever extension. I get a better extension with my Rome dissection and subperiosteal incisive in combination and faster, you know.
Just one more question.
It's a good kit. It's a good kit.
I saw that you only waited 4 months for the healing after bone grafting.
Yeah.
Why did you do that? Why didn't you wait a little bit longer?
Because of the choice of graft. I use it is a mineralized cortical.
I think it is important for the audience hear that. That's why I'm doing this question.
It is a choice of the graft that will render. It is a mineralized allograft that renders a modification of that remodeling of the non-vital and vital bone interface at a faster rate, almost compatible with natural bone healing.
We're
which
not,
is- yeah,
we are
Or-
not used to using it in clinical days in Portugal. We don't use it a lot. So we use a lot of xenograft mixed with autogenous graft and collagen membranes and titanium membranes, but it's not quite usual for us, especially in Portugal. I don't know what Jose and Olivia can tell us about that. But I'm really glad of your case, and I want to give your congrats for it. So keep on
thank
working.
you so much for you guys. This has been very special for me, sharing this with you. Thank you.
Anna, I can say I have quite a lot of experience with the allograft. It's a fantastic biomaterial, as she has described, particularly the corticocancellous mineralized, as she has very well described. I use it as in a particulate manner, and it's really a fantastic biomaterial which has evidence which allows us to re-entry between 3 to 4 months after reach preservation and not waiting 6. And she has described it very well, and she's tested, very well. Yeah, it is not so great in maintaining the space. Sometimes we combine it with the xenograft, or sometimes we add a connective tissue after the re-entry. Okay, okay, without
Yes.
raising the papillas.
Totally agree. Yeah.
I'm just joking. Okay, but thank you so much, Delmy, for sharing your case and for the
thank you.
enthusiasm and passion you've given to it. Okay.
Thank you. I'm honored.